department attached to Pugh Medical College. Dr. Arun did his MBBS from Raja Mudaya Medical College, Chidambaram. DNB Pediatrics from Indira Gandhi Medical College, Puducherry. And DM Gastroenterology from Stanley Medical College. He is presently working as assistant professor in medical gastroenterology, Anna Nagar Peripheral Hospital. He is also a consultant gastroenterologist and hepatologist and endoscopist at many private hospitals, including Apollo Hospitals, Greens Road. He has published research articles and he has also presented papers in national conferences. He participated as a speaker in many state, national level programs and webinars. And in this era of webinars, I could see sir's webinar sessions almost every day or alternate day as a webinar session to me also. He's such a great speaker. We are so grateful to you, sir, for accepting our invitation to be a speaker in today's CME. He's a member of Pediatrics and Gastroenterology, many associations. He is actually very apt to present today's topic on applied hepatic pharmacology, a clinician's overview, because he is also a pediatrician as well as he worked in Madras Medical College RGGH hepatology department for quite some time. So he is well experienced clinician. I request now sir to share his views with us regarding the applied hepatic pharmacology. Thank you, sir. Over to you.
Madam, my voice is audible, ma'am.
Yes, sir, it is audible. You can share your screen, sir.
Thank you very much, madam. And I would like to thank the entire department of pharmacology who gave me a wonderful opportunity to participate in this wonderful discussion. And I would also like to thank previous speaker, Dr. Anusha ma'am, who gave a very much detailed scenario what was happening in clinical pharmacology applied to the liver, and which made me work reasonably simple. And today my area of interest, so I'll be sharing my screen with you all, ma'am. Can you able to see my screen, ma'am?
Yes, sir. It is seen, sir. You are audible also. You can proceed, sir.
Applied hepatic pharmacology, yes, ma'am. So I would like to thank all the participants who are being here. And strictly I'll be going into my discussion about applied hepatic pharmacology in clinician's overview. See, if you're going to look into this forum, the main area for me to take on this discussion prior to the speaker who have given a reasonable, very brief introduction about various drug-induced liver injury, various mechanism of hepatotoxicity, how it's going to happen. All those phenomena have been discussed excellently by the previous speaker. But what is my implication? What is my area of interest to discuss with you all about in various clinical scenario? How are you going to approach? That's the main area for me to disclose with you all right now. So if you're going to look into this, the liver is such a wonderful organ which contains almost around 1.5 kg of weight, followed by, does almost around 500 varieties of functions. As we all know, the drug metabolism, which is predominantly is going to happen in your liver. So it plays a predominant role in the pharmacokinetics, and it's a site of biotransformation. And the liver blood flow, which is based upon the binding to plasma proteins and biliary excretion, all those things which is going to influence your pharmacokinetics, depends upon how your liver is going to get function. See, in a normally functioning liver, once a patient is going to get in a disease state, how the drug excretion pathway is going to set in, and all those phenomena is there. We are going to discuss with you all right now in this area. So based upon that, there are various clinical scenarios. If you're going to take into your liver, it could be because of infective pathology, it could be because of any metabolic events, right from pediatric age group or right from adolescent to adult. So many events, so many varied etiological focus are being there to consider this hepatic related drug manifestation. Madam, my voice is audible, na? Yes, ma'am. Kindly mute your voice, madam. So, if you're going to look into the data on the predominant liver diseases, which is going to rank almost in number 10 in top 20 causes of liver deaths, which is going to happen in India. This is what the data have been acquired recently. If you're going to look into that, in the Western countries, the data almost mainly because of the liver injury is going to happen by alcohol and hepatitis C virus. But in India, it's mainly by alcohol and hepatitis B virus, which is being taken over by, as published by our Indian Journal of Public Health. So there are various scenarios. Once the liver is going to get damaged, what is going to happen? The normal liver is going to get into the state of fatty liver. If you're going to be alcoholic, if you're not going to be alcoholic, see, if you have any queries, any doubts, you can feel free to stop me at any point of time. No problem for me to discuss. So the main thing, steatosis is a common phenomenon. It's a fatty liver which is going to get accumulated. Once a patient is going to have fatty liver, the patient's high possibility for them to go for evidence of steatohepatitis. What do you mean by steatohepatitis? It's nothing but the liver condition. The liver is going to get lethally involved, followed by your clinical presentation is also going to get worsened. Sometimes you may need hospitalization. Sometimes you may need a intensive care management, and followed by, once a patient, even after this, if the inflammation process, if it is going to get progress, there is high possibility for your liver to go for a cirrhotic phenomena. So nothing but a shrunken state of your liver, followed by, there is high possibility around 1 to 5% of the population can progress to a dreadful malignancy, which is nothing but hepatocellular cancer. Why I would like to point all those things, always, if you're working a patient for any diagnosis, if the patient is going to present for a jaundice, if the patient is going to have abdominal pain, if the patient is going to present with the evidence of fever, when you're going to work up such patients, always you should remember the drug-induced hepatic pathology. Always you need to keep in mind if you want to progress this phenomena successfully. So if you're going to look into the data in US, what they've been done, almost around 2,000 patients of liver failure, they have been studied. So what do you mean by liver failure? That I'll be discussing in my upcoming slides. See, if you're going to look into that, it's mainly because of pediatric population, which is going to involve acetaminophen. If you're going to look into this paracetamol, it's one common drug which is being usually abused in the pediatric age group. Adult population, paracetamol poisoning is not much common but in India, but in pediatric population it's more common because of the various formulations which is being available. If you're going to take a drops, it contains almost 1 ml, 100 milligrams in 1 ml. But if you're going to take a suspension form, it contains 125 milligram or 250 milligrams in 5 ml. So most of the mother population who are being illiterate, they'll be using 5 ml just like that, even in a smaller age group who have been recommending a dose of around 10 to 15 milligrams per kg, followed by they might be giving a very huge adult dose, which most of the patients won't be knowing. This may lead to lethal liver hepatic injury. So always you should remember, based upon your King College criteria, our transplantation guidelines, what we mentioned, either by acute liver failure, whether by paracetamol-based or non-paracetamol-based poisoning. Next to that, there are multiple reasons for you to develop a jaundice because of various hepatic insults, which is going to happen by your drug mechanism. That I'll be taking over in my upcoming slide. So in India, the another common important entity is anti-tuberculosis drugs. I think the previous delegate participant have been asked about how to introduce anti-tuberculosis. That I'll be discussing with you all right now when I'm taking my discussion. But anti-tuberculosis drugs, you always should be very, very cautious, because I have seen many patients in my experience who, after initiating an anti-tuberculosis drug, most of the patients may land up with massive liver injury. So we might be thinking that it's only because of anti-tuberculosis. Not like that. We always should work up the patient. It could be because of anti-TB, even in the background of tuberculosis medication, but always we need to rule out other possible infective pathology like hepatitis E, or coexisting acute flare of hepatitis B, or in the background of HIV. So many other coexisting parameters will be there. Always you need to look into that account if you're going to manage a patient with this kind of scenario. So if ruling out all the possible events, anti-tuberculosis drugs can be considered as a strong pointer. And at that point of junction, we need to stop the medications for a while, followed by we can take on with slow stepping up, as what madam has been discussed in the previous talk. So why I'm discussing this, it can predispose you to acute liver failure. It's almost contributing around 5 to 20% of the population, which leads to acute fulminant hepatic failure. This is a basic pathophysiology, how the drug is going to influence. I think that this slide has been shown by the madam in the previous talk, but what I would like to implicate, any drug injury. It could be, as Madam discussed previously, it could be because of idiosyncratic, or it could be intrinsic pathway, which is direct toxicity, or it be indirectly, which is going to get involved. Why I am going to point out, mainly by a mitochondrial injury, or mainly by your intracellular stress pathway, if it is going to get activated. If it is going to get activated, there might be evidence of apoptosis. Once the pro-apoptotic pathway is going to get activated, there might be evidence of band, or your pro-apoptotic gene is going to get involved. Your caspase activation is going to be there, followed by your hepatic injury is going to get progress. So it could be because of massive mitochondrial injury, or it could be because of your intracellular stress pathway, or it could be because of your sensitization, your tumor necrosis factor, or it could be because of your immune response, which is going to get involved. All these things which will be predisposing to apoptosis, which is one of the dreadful complications, going to get progressing in the pathophysiology, followed by the cell necrosis, and the final pathway of cellular failure, mitochondrial death. All those things is going to set in. Even the patient is going to get induced by any drugs. So always it's going to be a reactive metabolism is going to get formed in the mechanism. So based upon the various scenarios, one thing, the oxidative stress, that means the glutathione levels, if it is going to come down, as we are looking into that, the paracetamol poisoning is one common phenomena in which we are going to have a depletion of your glutathione. So our motive, we are going to give your glutathione supplement. That's why we are going to give the patient an acetylcysteine, which is going to replenish your glutathione stores, followed by your level of injury may come down. Once you're not going to treat promptly in the right time, there is high possibility for this paracetamol poisoning to progress to liver failure. So this is a basic outline about how the drugs are being causing your liver injury, what is going to happen, what is the various mechanism because of your, see, once the immune injury is going to set in, there might be evidence of glutathione depletion, your mitochondrial injury, which will inhibit your cell regeneration. All the transporters are going to get inhibited. The bile salt pump exporters are going to get activated, followed by, there might be evidence of various injury. It could be because of hepatocellular pathway, or it could be because of your cholestatic pathway. So there might be a various injuries based upon your various metabolites, which is going to get involved. So briefly about the, as already been discussed, my area, to touch this area very briefly, because as you all know, the drug toxicity is mainly by phase 1 and phase 2 metabolism of the drugs, which is occur mainly by two-phase reactions. So phase 1, oxidation and conjugation, followed by, once a polar species, if it is going to get formed, it might be excreted in the urine. But stable adducts, if it is going to get formed, the non-polar species will be predominantly excreted in your biliary pathway. This is how the metabolism of most of the drugs is going to get set in. As we all know that the pharmacology is being well aware about this CYP450 enzyme inducer pathway. Recently also I given a lecture about this. See, why I would like to point out, because one major, suppose if you're going to give proton pump inhibitors with clopidogrel, what is going to happen? It may predispose to major acute coronary events. So that, even though it's the area of not much in the area of discussion, why I would like to point out, if you're going to prescribe even proton pump inhibitors to any patient, always you should be cautious. You need to look into an account whether this patient can have an enzyme inducer which is going to get activated or not. This PPI can inhibit the level of clopidogrel, can worsen your major acute coronary events. Why I would like to point, whenever you're going to give any molecules to any patient, assess the age of the patient, assess the sex of the patient, assess the race, assess the genetic polymorphism, is any comorbidity is there or not, whether the patient is diabetic, whether the patient is hypertensive, look for the clinical status, rule out any evidence of malnutrition. All these pointers, all those clinical examination is the most important way for you to take my discussion, because once you are having a strong clinical examination, you are almost in. So if your examination is good, you can able to analyze which is the molecule you are going to target, which is the area is going predominantly to be targeted, followed by what is the drug which you are going to use to target, and with less of interactions. That's the most important thing as a pharmacologist for you to decide about the management when you're going to see a patient who is terribly sick. So why? So most common causative drug classes, which has been reported in various studies, have been done in Spain, US, and Latin America, and Iceland. What we mentioned is anti-infectives is predominantly more common. In India also, there have been studies which have been shown evidence of anti-tuberculosis is one of the most common cause of drug-induced liver injury, and antiretroviral also been predisposed, and all these mechanisms. So what is a common presentation? It can be very varying forms. So it can be because of asymptomatic, or it can be present as acute hepatitis, or it can be presenting as a chronic hepatitis, or it may be landing as acute liver failure, which deserve liver transplant, and finally to end-stage liver disease once a patient is going to get decompensated by developing ascites, severe coagulopathy, hepatic encephalopathy, all those things. If it is going to get worsened, there might be evidence of possibility because of this drug-induced liver injury also. So why will we like to point the basic definition? You're all well aware. This is previously slide, previous notes it has been discussed. The earlier definition mainly always you should take care of three major enzymes. One is by hepatocellular pathway and one is by cholestatic pathway. Cholestasis is nothing but your bile flow if it is going to get impaired anywhere between your biliary tract to the duodenum. So if it is going to get impaired, it could be because of genetically mediated or metabolically, or it could be because of obstructive focus. There are multiple etiology based upon your level of bile duct which is going to get obstructed. Why I would like to point this thing is, so the definition is being keeps on revising. There are so much of laws are being improvising, and you're going to look into this concept. So the drug-induced liver injury is mainly the transaminases because of your hepatocellular injury and your bilirubin, if it is going to be more than 2 times of the upper limits of normal, is one of the initial presentation. But what they've been taken as a recent cutoff is if your ALT or AST, if it is going to be more than 5 times, and your ALP, if it is going to be more than 2 times, and your bilirubin, if it is going to be more than 2 times, that might be show some evidence that the patient is going to present with a drug-induced liver injury. So remember these 3 major important things before you're going to wind up this section. That's the most important. Remember this simple law in basic pharmacology. Heist law is very important because it's named based upon Hyman Zimmerman, who discovered a combination of jaundice and drug-induced hepatocellular injury was associated with high fatality rate because of liver failure is going to get developed. So if you're going to look into the Spanish registry, what they've been mentioning that once the patient is going to progress with high bilirubin levels, along with this new, Haar ratio. What is this Haar ratio? I'll be showing in my upcoming slides. Once a Haar ratio, if it is going to get involved, there is high possibility for this patient, the sensitivity and specificity for this patient to progress to worsening of hepatic injury is definitely going to set in. My slides are visible? Can you able to see my slides?
Yes, sir.
Yeah. So basic epidemiology, what you are going to look into this, it's almost the drug-induced liver injuries. Always you should remember it's only a diagnosis of exclusion. So once you're going to exclude, so incidence is almost around 1 in 10,000 to 1 in 10 lakhs. 1 in 1 lakh, followed by the overall fatality will be approximately 0.1. In India, it's almost contributing to 1.4 of all gastrointestinal admissions and 2.5 of all hepatobiliary admissions. So the basic initial pathology is nothing but based upon your predictable or an unpredictable scenario. If it is predictable, it could be dose-related hepatotoxic or intrinsically hepatotoxic drugs or acute injury, or it could be because of a fulminant injury, as initial speaker been discussed about this acetaminophen, all those anti-cancer which is going to get involved. So unpredictable because of any adverse drug reactions is going to get happen. There might be evidence of long latent period and extrahepatic features of drug hypersensitivity. There's always a combination which is going to get involved in that. Though the risk factors for drug-induced liver injury is usually been there, but if you're going to look into the clinical presentation, it's the most important thing. The age of the patient, the gender, the body mass index is nothing but your weight in kg by 8 meters square, followed by your alcoholism, whether the patient is alcoholic. See, if the patient is going to be alcoholic, you need to see what is the dose, what is the alcohol content, how long the patient is going to consume, whether the patient is male or female. All these things has to be important when you're going to calculate the lethal dose which is going to set in because of your drug or because of your alcohol. So all this phenomena to be looked into an account. And what's genetic pathway, your COAP polymorphism, an underlying basic event, whether the patient is having chronic liver disease or based upon your pharmacological properties like your COP, P450 substrate is going to get involved, or degree of lipophilicity and your hepatic metabolism pathway. All these things, drug-drug interactions, that's what I've been discussed with you. All those things has to be taken into account if you're going to look at a patient who presents to us with evidence of DILI. And next to this, what do you mean by the terminology called chronic drug-induced liver injury? Because 1 year after the onset of your acute presentation, the biochemical parameters are still worsening, continue to be abnormal, your imaging is continuing to be abnormal, that chances may occurs in about 10 to 15% of the population who presents to with evidence of acute acute drug-induced liver injury. This may also possible for this kind of patients to progress to cirrhosis, and this scenario may represent an autoimmune hepatitis which might respond to your steroids. So why I would like to point this, if you're going to look into this graph, it could be because of your acute DILI, or it could be because of your chronic DILI, or this chronic DILI with multiple episodes of your liver abnormality, which is being set in a time interval of around 1 month from the onset. So if you're going to see in chronic DILI, which is going to land up with multiple episodes of continuous liver abnormality, that shows evidence that the patient is progressing to your chronic drug-induced liver injury. This is the area, what are the various clinical presentations? Huge number of presentations are there based upon your drugs, which is going to predispose, what kind of drugs you are going to use, followed by what are the various mechanisms your liver injury is going to, what are the various diseases you can predict because of this liver injury. One is because of your autoimmune pointers. Always you should remember, autoimmune is very one characteristic entity. Mostly it will be reporting in females. As we are well aware, there are so many markers are being there to diagnose this autoimmune hepatitis. Apart from that, how do you going to label this patient is going to be having evidence of drug-induced? Always you need to remember that various things like antinuclear antibody or liver kidney microsomal antibody, all those things, antibody levels, if it's going to be normal, and if you're going to look into your autoimmune focus, that shows evidence of a drug which is going to predispose, then there is substrate. Once you're going to do a liver biopsy to this kind of patients, if you're going to look into the focus of autoimmune, that shows a clear evidence that this patient is mainly developing this kind of problem is because of your inciting drug. So it could be because of your vanishing bile duct syndrome. So vanishing bile duct syndrome is nothing but your bile ducts is going to completely distracted, followed by your various reasons, which is going to be, it could be because of your infective pathology, or it could be because of your drug-induced like amoxicillin cloud, in which we are going to commonly use antibiotic for very multiple respiratory other common scenarios. And apart from that, your drug-induced steatohepatitis is one common area which is being progressing very high in the Western countries, also being reporting in our countries now because of your various drugs. It could be because of steroids, or it could be because of antiarrhythmic molecules, or so many other molecules are being there. And sinusoidal obstruction, if the patient is going to have a hematological malignancy, if you're planning for a stem cell transplant, in those kind of conditions, if you're going, there is high possibility for your sinusoids may get obstructed, which may predispose to jaundice, followed by a drug-induced liver injury is going to set in. So severe DILI is nothing but the scenario is almost like acute liver failure. The INR, if it is going to be more than 5, once a patient is developing ascites, which is nothing but accumulation of fluid in your peritoneal cavity, followed by the patient is going to land up in hepatic NCAF. If you're going to look into hepatic NCAF, there are various grading systems. That's not my area to take into account, but always you should remember the covered as well as overt hepatic encephalopathy is there. Once a patient is having evidence of covert hepatic, which is nothing but grade 1 to 2 hepatic NCAF, that shows evidence of worsening of drug-induced liver injury. Always you need to look into the pointer, look for other coexisting pathology, that what I've been discussed with you in my initial slides, to label this patient mainly because of drug-induced liver injury. These are all the various mechanisms that have been discussed previously also. One is by intrinsic, idiosyncratic, mitochondrial, and bile export pump, which is going to get involved. And these are all the various mechanisms already been discussed. This intrinsic hepatotoxicity is mainly, which is going to be a short latency, and idiosyncratic, which is being a long-standing duration by your antituberculosis medication. Intrinsic is mainly by your paracetamol. So if how the disease is going to set, that's what been discussed. So once the initiation of injury is going to get happen, there might be evidence of adaptation. Once the adaptation, if it is not going to set in, that shows evidence of worsening of your clinical presentation. The clinical presentation like your nausea, vomiting, anorexia, fatigability, and it might be having evidence of your regeneration, whether it's going to happen or not, or whether the patient is going to have a severe liver injury followed by liver failure or death is going to get reported, is only a questionable issue to be answered properly. And next to that, What are the various patterns? It could be because of, as you have been discussed, the R ratio is nothing but based upon your COMS, that's Council for International Organization of Medical Sciences, what they've been discussed from your US FDA. So if you're going to take a R ratio, that ALT by ALT of upper limit of normal, and by ALP of upper limit of normal, what they've been checking, once your R ratio, if it is going to be high, that ALT to ALP ratio, if it is going to be high, more than 5, it shows a clear pointer that this patient is involved mainly because of your hepatocellular injury. But in case if it is because of cholestasis, the ALP ratio is going to be significantly high. That shows R ratio, it will be around less than 2. It shows a cholestatic pathway. And if it is going to be mixed, it should be in between 2 to 5. So the various common reasons, the clinical pathological classification, that's what I've been discussed: acute event, asymptomatic, dose dependent, a granulomatous event, a cholestatic event, or chronic hepatitis, or it could be because of fatty liver, or it could be because of a non-alcoholic steatohepatitis, or it could be because of veno-occlusive, or there might be some evidence that drugs is going to predispose to hepatic neoplasms. Also, I'll be showing in my upcoming slides. So this dose-dependent hepatotoxicity is going to be having a zonal necrosis predominantly involving, if you're going to look into your hepatic zones, is one very complex area to understand. It's mainly in your zone 1, which is going to predispose to, my voice is audible? Which is going to predispose to submassive as well as your pan-acinar necrosis, which will be mainly where acetaminophen and methotrexate is going to be there. See, and one thing I would like to show, because the previous delegate, I mean, tuberculosis, which is going to get involved. Once the patient medications, what is going to happen? That shows evidence of liver injury. So once your liver injury is going to set in, always you should remember that you can mainly you can reintroduce the drug by slowly, as what Madam has discussed, like initial slow titration, starting from INH, then to, starting from rifampicin, then to INH, then to pyrazinamide at last. So there are so many guidelines being given accordingly. So how do you going to, because based upon American Thoracic Society and based upon your British Thoracic Society, what they mentioned, so if you're going to look into 8 years, so rifampicin, you can start at maximum dosage from day 1, but isoniazid, you can start at maximum dosage from day 8, and pyrazinamide, you can start at maximum dosage from day 15. But what they mentioned in this BTS Society, if you're going to start isoniazid, can be started from day 1 at a minimal dose like 100 milligrams, followed by you need to step up slowly for a maximum dosage from day 4 onwards, you can proceed. And if you're going to start rifampicin, you can start at 150 milligrams per day from day 8, followed by maximum dosage you can go from day 11 onwards. And pyrazinamide, always you should be very cautious because it's one of the major hepatotoxic molecule. So start at a dose of 500 milligrams from day 15 onwards, and you can reach your maximum dosage. But you need to titrate your liver parameters once in 3 to 5 days. That's the most important thing when you're going to switch on this kind of molecule slowly if you're going to reintroduce. And always you should remember to which patient you're going to reintroduce, whether the patient is having evidence of liver injury, or the patient is going for cirrhotic background, or whether the patient is going for compensated cirrhosis or a decompensated cirrhosis. All these parameters to be taken into account if you want to manage this kind of scenario. So based upon your Child-Pugh criteria, you all remember should work basic thing, based upon your prothrombin, based upon your bilirubin value, based upon your encephalopathy, all those parameters, 5 parameters to be taken into account if you want to look into your Child-Pugh status. And once a patient falls in Child A, you can start with 2 hepatotoxic molecules. And once a patient is going for Child B, you need to start with 1 hepatotoxic molecule. But once a patient is going for Child C status, which means worsening of almost, and the Child status, if it is going to be more than 8 to 11, that shows you need to start no hepatotoxic drugs to be introduced. You can use only a second-line molecule like ethambutol or streptomycin or ioquinolone. So remember this important algorithm for starting a patient with anti-tuberculosis medications when you're going to treat this scenario. What do you mean by next other important entity is nothing but your autoimmune based DILI. So autoimmune mechanisms, as we all know, there are various type 1, type 2, so many autoimmune hepatitis are there. And next to that, mainly by your drug-induced autoimmune hepatitis, various reasons, by nitrofurantoin, methyl depot, so many causes are there. What is going to happen? So if you're going to look into this, there might be evidence of your prominent plasma cells, which is going to get infiltrate. Why we need to diagnose this autoimmune? That is also one more diagnosis of exclusion, because we need to rule out common infective pathology. Once you're going to diagnose this autoimmune hepatitis, there might be showing some evidence that this kind of patient is going to show reasonable response to your corticosteroid. So once you're going to start your corticosteroids, you need to serially monitor this kind of patient, whether it is improving or not, followed by, if the patient is improving, you can continue the molecule. But once the patient not shows much of signs of improvement, ideally you need to discontinue the molecule. But this thing should happen only in hepatitis pathology, but not in the background of a cirrhotic event. So when you're going to start steroids, it should have evidence of only drug-induced liver injury, followed by it should predispose to only autoimmune hepatitis, but not by a cirrhosis or decompensated pathway. Once the patient develops ascites, you're not supposed to use corticosteroids in the management process of autoimmune hepatitis. So what is this granulomatous hepatitis? So once the patient, so there's so much of list of huge causes, there might be evidence of a non-caseating microgranulomas, which is going to predispose. It's one of the complex phenomena, even for the gastroenterologist to diagnose this clinical scenario, because granulomatous hepatitis is 2.5% of the populations can be because of drug-related injury. Most commonly, haloperidol, your carbamazepine, so many drugs are there to predispose. So you can see this granulomatous injury mainly in your portal tract. So if you're going to look into your portal tract, you can see this granulomatous injury, which is going to be there. So once the patient's having hepatic granuloma, you can identify by your liver biopsy. So that shows some evidence you can identify by your liver histology, and 2.5% of the causes is mainly because of your drug-related pathology. And next to that, what do you mean by this acute fatty liver? So if you're going to look into this acute fatty liver, it's nothing but a rapid steatosis which is going to get formed. Once a patient is going to get rapid steatosis, for example, if you're going to look into the scenario of Reye's syndrome, there might be evidence of hypoglycemia, lactic acidosis, hyperammonemia, your cerebral edema, the microvesicular steatosis which is going to get formed, followed by this kind of patients will be having evidence of acute onset of hepatic encephalopathy, acute worsening of presentation. So the most common drug which is being predisposing for this acute fatty liver will be, as you all know, that it's mainly because of your anti-epileptic molecule like valproate can be considered in the pathophysiology of acute fatty liver. There are so much of lists are there for this drug-associated fatty liver disease. It's mainly because of your tamoxifen, or it could be because of your amiodarone. Amiodarone can predispose to multiple other complications also, and it can predispose to because of your carbamazepine that can be used. When you're going to consider all this, see, what do you mean by fatty liver disease? If your liver fat, if it is going to be more than 5% of your total hepatocyte content, that shows evidence of your fatty liver is there to progress. Now, there are so many investigations are there to identify your fatty liver that out of area for discussion right now, but you should remember that the fatty liver, isolated fatty liver, steatosis, followed by steatohepatitis, followed by cirrhosis, followed by hepatocellular cancer is one dreadful entity you need to recognize as early. And any patient who diagnosed to have evidence of fatty liver, look for evidence of metabolic syndrome. Once a patient is going to have evidence of metabolic syndrome, treat the patient. Diet and lifestyle modification is the most important parameter to address promptly if you're going to manage this kind of scenario. And next to that, what do you mean by the drug-associated fatty liver? That what I mean discussed with you all, if the fat, if it is going to be more than 5%, and always the alcohol consumption should be less in this kind of background. It should be around less than 21 units in men, and it should be less than 14 units. Don't think that non-alcoholic fatty liver doesn't mean the patient should not consume any alcohol. Not like that. The patient can take a minimal amount of alcohol, but it should be having a coexisting other pathology. That what I've been discussing with you all, a metabolic syndrome and other, all those parameters to be taken into account. But if you're going to look into by the molecules, very commonly by amiodarone, methotrexate, tamoxifen, all these things to be taken into account if you're going to manage a drug-induced steatohepatitis. there are huge list of causes for this cholestasis pathway. Once your cholestasis is going to get activated, the bile flow is going to get obstructed, either from anywhere in the biliary tract, or it can be anywhere in the duodenum, either be your metabolic process or because of your export pump, which is going to get involved, or whether because of your obstructive pathology. It could be because of your intrahepatic, or it could be because of your extrahepatic. One day won't be enough to talk about this cholestasis pathology, because it's one of the wonderful events. And among this cholestasis, the cause of drug-induced very meager. But even then, when you're going to for this discussion, so cholestasis without hepatitis, and cholestasis with hepatitis, and cholestatic hepatitis with bile duct injury, and sometimes evidence of chronic cholestasis. There are a huge list of causes that you can, anytime you can go through that, but it can predispose to bland cholestasis, mainly by your anabolic steroids. Remember that in oral contraceptives. And cholestatic acute hepatitis mainly by your antibiotics and vanishing bile duct. Always you should remember your antibiotics and your psychotropic medications. And what do you mean by the secondary sclerosing cholangitis? If you're going to look into your bile duct, your intrahepatic bile ducts will be having a beaded appearance. It may be having the potency of your bile duct, which is going to come down. It is going to take a beaded form. The size is going to get constricted, followed by that shows evidence of primary or secondary. Once a patient is having primary, it is going to be idiopathic. Most of the time, the cause could not be identified. But if the patient is going to be a secondary, that shows evidence of drug-induced. Could be also one more, add-on to a strong pointer to consider in the armamentarium of diagnosis of secondary sclerosing cholangitis. It could be because of docetaxel, or could be because of ketamine. So many lists are there if you want to look into that. So cholestasis without hepatitis means that shows no evidence of hepatic injury, but there might be evidence of cholestasis mainly by your sex steroids. And cholestasis with hepatitis, if you're going to look into this, mainly by your chlorpromazine and other drugs. And if you're going to look into your cholestasis with your bile duct, is also going to get injured, and followed by it is going to be diagnosed by a liver biopsy. Most of the time, the recovery will be ruled if the liver biochemical test, if it is going to be improved within a period of 1 to 3 months, usually will get improved. That shows some evidence because of your antibiotics like flucloxacillin and chlorpromazine, if it is going to get involved. Chronic cholestasis, always you should remember that if it is going to be more than 3 months with the cholestasis, your ALP level, if it is going to be high, persistently high, and which shows evidence because of erythromycin or chlorpromazine, or because of flucloxacillin, what is going to happen if you're going to look into histology, that shows evidence of irreversible loss of biliary patency, and this may also predispose to vanishing bile duct syndrome. Always you should remember the secondary sclerosing cholangitis, that what have been discussed, it's the stricture which is going to happen in your bile duct. It could be because of your ischemia or because of your drug toxicity. So many mechanics are there. It's a separate area for discussion. And once the patient is going to have secondary sclerosing cholangitis, if you're going to look for a beaded appearance, mainly by your chemotherapeutic agents like docetaxel can be involved. And drug-induced tumors is also to be recognized being hepatic events. As we all know, hepatocellular carcinoma is well-recognized common entity because of your hepatitis C, hepatitis B, alcohol as a co-carcinogen, and various events like alpha-fetoprotein, alpha-1 antitrypsin, so many other metabolic and other parameters to look for hepatocellular cancer. But what are the various drugs can predispose to liver cancer? The common one, mainly by your hepatic adenoma, which is predisposing mainly in women population who are going to be exposed to oral contraceptive pills for a longer duration of time, almost around 1 to 2 years of time. If the patient is going to be there, that shows evidence of hepatic adenoma. The case reports are being there. And next to that, various other tumors like focal nodular hyperplasia, which is almost like a benign condition, mainly by your OCPase, and your hepatocellular carcinoma, rarely by your drug injury because of androgens, as well as methyl testosterone, and angiosarcomas, mainly by androgens, and your cholangiocarcinoma. And there's so much of list of causes for this drug-induced, hepatic tumors can predispose. If you're going to remember the basic pointers, is well and good for you to take on this discussion. Next to that, this is the brief outline that what have been taken from your standard textbook of gastroenterology. So what they've been mentioned in that, the various huge list of drug-induced hepatovascular disorders like your sinusoidal obstruction, nodular regeneration, non-cirrhotic portal hypertension. What do you mean by non-cirrhotic? So if you don't mind, if you're going to mute, it's well and good. So what do you mean by non-cirrhotic portal hypertension? As you all know, portal hypertension, any patient who is going to present to you with evidence of splenomegaly in the background of esophageal varices, in the background of a massive upper GI bleed, that shows evidence of portal hypertension. In the background of cirrhosis is there or not. If the cirrhosis is not going to be there, but this kind of parameters, if it is going to be there, based upon that, your non-cirrhotic portal fibrosis, portal hypertension is going to get diagnosed. The most common event which is going to predispose to this kind of scenarios by high dose of vitamin A, if you're going to supplement for this kind of population for a longer duration of time, that shows evidence of non-cirrhotic portal hypertension to develop. And your peliosis hepatitis by your anabolic steroids, and it's almost looking like hepatomegaly, your hepatic rupture, your liver failure, and sinusoidal dilatation. Always you should remember, once your liver sinusoids, that it's going to get involved, there might be evidence of rapid onset of ascites, there might be evidence of hepatomegaly, there might be evidence of abdominal worsening pain, which mainly will be predisposing by your oral contraceptive steroids. And always you should remember that sinusoidal occlusion or obstruction syndrome, or what is going to be there mainly by your bone marrow transplant, how the scenario is going to present by your rapid onset of ascites, your worsening of liver failure, in the background of your worsening of your portal hypertension. So remember all those things. And this one more new entity for me to take on the discussion about specific tumors, like what I mean, the androgens and oral contraceptives, androgens and androgenic steroids, all those things will be having a worsening of human, that what I've been discussing in my previous slide. And based upon your checkpoint inhibitors, based upon your cancer chemotherapeutic agents, what you're going to use. For example, when you're going to consider ipilimumab or nivolumab, CTLA, cytotoxic lymphocyte inhibitors or PD-L1 inhibitors, if you're going to use for a longer duration, that shows evidence of worsening of your tumor. That shows evidence of, because of this immune checkpoint, that might be evidence of hepatotoxicity can happen. So always you should remember, even the cancer immunotherapy molecule can also predispose to drug-induced liver injury, mainly by ipilimumab or nivolumab, when you're going to use for a longer duration of time. And next to that, drug-induced liver injury is mainly a diagnosis of exclusion. So you need to work up the patient for your HCV RNA, your anti-HCV, B status, your infective profile, your complete metabolic profile. You need to do a baseline ultrasound examination. You need to do your fibroscan. Now, the recent investigation like fibroscan has been taken, which has been the advent of fibroscan in the field of diagnosing fatty liver has been too high. So you can do a fibroscan. And liver biopsy, always you need to consider for a patient to whom you couldn't able to establish a diagnosis, or if the patient is going to have a worsening of DILI, or whether the patient is going for chronic DILI. So all these conditions in which the liver biopsy can be done, but that should not be evidence of any worsening of coagulopathy. At that point of juncture, you need to be very cautious when you're going to touch your liver. And next to that, so the determining casualty, the diagnosis mainly by the various scoring system, as what I mean discussed, your casualty results, ICLAF casualty assessment. You need to assess the clinical scenario, your SIAMS assessment method. All those methodology can be used to analyze your results, ICLAF scoring system. High possibility if the patient is going to have a score of almost around 8 to 10, which means when the drug has been initiated, when the drug has been initiated, when the drug has been stopped, all those parameters to be taken into account, whether the patient, based upon your age, whether the patient is alcoholic, whether the patient is pregnant, coexisting drugs, all those things to be calculated for your RUCAM scoring, for assessing the severity of your drug-induced liver injury. So this is the stepwise approach. So proper history assessment, look for the basic biochemistry, look for evidence of the drug which is going to get exposed, and look for any evidence of over-the-counter drugs which is going to get used, and calculate your R ratio, see whether the pattern of injury is mainly because of your hepatocellular or cholestatic or mixed pathway, and rule out also always the other common etiology like infective pathology or any vascular occlusion or any other infection or any benign lesions or any malignant obstetric lesions, or it could be because of primary biliary, or it could be because of secondary, primary sclerosing cholangitis. These are all different entity which has to be strongly considered in the background of a cholestatic jaundice. Always you need to see whether the patient is having intrahepatic or extrahepatic pathology. You analyze the history properly to diagnose. And in case if you couldn't be able to identify any common scenario, consider the patient for liver biopsy, and then you can able to conclude this patient is mainly because of drug-induced liver injury, which is going to supervene or not. This is how the outline, what I've been discussed with you. So look for any evidence of DILI. Also look for any other organ system. For example, if you're going to look for your autoimmune hepatitis, it could be having coexisting thyroid or any other autoimmune pathology like Sjogren's. So many other conditions can be there. You look into an account. If you want to diagnose a clinical picture of your drug-induced liver injury is only precipitating factor, ruling out all possible pointers. That's the main thing I want to include here for the discussion. So the future prospects, I think the previous speaker, madam, who have been discussed about this. So what are the future prospects to diagnose this drug-induced liver injury? As you all know, this HMGB, it's nothing but if you're going to look into the newer markers like, I molecular, if it's a global protein, if it is going to get considered, and your various coexisting new markers like your apoptotic activation factors like your keratin, your caspase, CSF pathway, and next to that, your microRNA, your glutathione dehydrogenase, your all succinate, all those parameters can be newer markers can be taken into account if you want to look for your newer biosafety biomarkers for your liver safety, it's there or not. So the unresolved issues, clinical diagnosis is very complex, ruling out the other possible events and look for the response and whether the patient is responding, and look for whether the precipitating event is there or not, and what is the major massive treatment regimen to be established if you're going to manage this protocol. So apart from this area of discussion, the other entity, so what is going to happen once the patient is going to land up with this liver cirrhosis and other things? The basic pharmacology, if you're going to remember, once a patient is going to get developed, once a patient is going to land up with liver disease, it could be because of head to foot. You need to look for evidence of hair loss, look for evidence of jaundice, look for evidence of spider nevi, look for evidence of pedal edema, look for evidence of hepatomegaly, look for evidence of splenomegaly, look for evidence of ascites, do endoscopy, see for evidence of esophageal varix, all those pointers, as you all know, look for evidence of hepatic encephalopathy. So rule out any coexisting other organ system like renal injury, which is also very common, like hepatorenal syndrome. So many things are there for discussing. So once you're going to diagnose this liver disease, see whether the patient is going to respond. See, based upon your AST and ALT parameter, and see whether the patient's plasma, once the patient is going to have a protein leak, what is going to happen? There might be a microbial dysbiosis, which is going to get set in, followed by your albumin, it's going to get come down. Once your albumin, if it is going to come down because of outpouring of proteins, because of your various pathways is going to get involved, what is going to happen? There might be having all the synthetic capacity of your liver is going to come down. So once your albumin, if it is going to be less than 3.5, that shows evidence that the patient is going to progress for your pedal edema and ascites. That shows the clear pointer. This is child book score. What I would like to point based upon your ascitic, bilirubin, albumin, your prothrombin, and your INR, all these parameters along with encephalopathy status to be taken into account if you want to manage the patient with this. So what are the various things which may affect your liver metabolism? One by hepatic clearance, your clinical presentation based upon your plasma protein production, whether it's bound to albumin or not, and next to that, whether the patient is having high first pass metabolism, and because of your high extraction drug or intermediate extraction drug or low extraction drug, what is the drug which is going to get used, followed by how far your bioavailability is going to get utilized, followed by your drug metabolizing enzymes activity. These are all the area of pharmacology. I will be briefly touching these areas because that's not my main interest for me, apart from talking to you all about the clinical discussion. So if you're going to look into this, once the patient is going to land up with severe hepatic disease, that shows evidence of decrease your first pass mechanism, the first pass metabolism pathway which is going to get involved, that shows evidence of high bioavailability. So that is what is going to happen when you're So most of the drugs which is going to use mainly based upon your plasma protein, your tissue binding, as well as your lipid solubility, which is going to get involved. So plasma proteins like albumin, if it is going to get decreased, there might be evidence of worsening of injury. And this kind of hepatic injury patients also may have a renal function, could be having a coexisting renal injury also. And this is also the mechanism. Most of the drugs can be eliminated through renal route also. Also, all these pointers can be considered if you're going to manage. This is the basic pharmacology. I think you will remember that. So based upon your high extraction or low extraction or intermediate extraction pathway, what they're going to discuss, once if it is going to affect your bioavailability like your cirrhosis or portal hypertension, so what is going to happen? There might be evidence of this. So once if you're going to use the high extraction drugs, what you're supposed to do, the most important thing, you need to give a normal initial dose, and the maintenance dose can be given, and the maintenance dose has to be strongly reduced. But once you're going to use a low extraction, what is the low extraction? Nothing but the first passage metabolism will be less than 30%, which will be predisposing to your high bioavailability more than 70%. So what is going to happen if you're going to use this low extraction drugs? So the maintenance dose of the drugs also to be reduced if you're going to use a low extraction drug. So there are so much of list of drugs are there for high extraction, low extraction, and intermediate extraction. So based upon that, you need to analyze your child status, and based upon the maintenance dose, whether it's child A 50%, child B 25%, and child C almost a regular person has to be given. And based upon your albumin fraction, you need to analyze all this data properly. And bounding of albumin, if it is going to be a drug, if it is going to be more than 90%, if it is going to bond to albumin, that shows it's not only because of your metabolic enzymes, also it's because of your albumin pathway which is going to get involved. All these things to be targeted if you want to manage a patient with drug-induced, manage a patient if you want to establish a proper pharmacokinetics in the background of a liver injured patient. So this is also about the intermediate extraction dose, in which you are going to, since the bioavailability slowly rises, so the therapy has to be started with initial low dose, but for maintenance dose, it can be calculated as that of a low extraction drug. So when you're going to manage, remember the 4 parameters: look for bilirubin, look for PTINR, see whether the patient's albumin range, if it is going to come down less than 3.5, and look for evidence of worsening of your liver enzymes is there or not. And recommendations, no single tests have been significantly proven. The clinical parameters, your baseline liver function, the sensorium, all those things to be taken into account based upon the clinical presentation. What are the molecules you are going to choose, apart excluding your all the basic common infective pathology, and to be considered in the management of drug-induced liver injury when you're going to target. The new other entirety, what you're going to implicate here, the nutraceuticals. If you're going to look into this nutraceuticals impact in liver, there are so many hepatotoxins that are being there because of your herbal products or vitamins, which is going to be used. What they mean, dietary supplements, what they're going to give. So if you're going to use, how is going to get involved? One thing I would like to discuss about the role of probiotics, because this is one common area nowadays being used everywhere. What is this probiotic? If the microbiota imbalance, if it is going to get disrupted, what is going to get happen? That shows evidence of your PAMP and DAMP, nothing but the pathogen associated molecular pattern and your damage associated molecular pattern if it is going to get activated. And once your eubiosis, if it is going to be completely disrupted, there might be evidence of your symbiosis. If it is going to come down, there might be evidence of your dysbiosis is going to be established. Once a dysbiosis, if it is going to get established, that shows evidence of worsening of your infective pathology, worsening of your hepatic encephalopathy. All those things is going to be predisposed mainly because of your microbiota, which is almost considered the next brain of a gut, which is to be targeted properly. So why I'm looking into that, there are various nutraceuticals, mainly because of your hepatocellular production, mainly because of your oxidative stress, which is going to get involved, like vitamins and omega-3 fatty acids, vitamin E, C, D, all those things to be taken into account. But one important target you should remember in the role of non-alcoholic fatty liver disease, the vitamin E can be strongly considered because it is going to act on your oxidative stress and it is going to have a hepatocellular protection. And also you can consider omega-3 fatty acids if you're going to manage a patient with non-alcoholic fatty liver disease. And apart from that, there are possible multiple nutraceutical benefit for various conditions you can try, like carnitine, vitamin C, omega-3, vitamin D, and silymarin, which is being strongly used for oxidative stress because of your alcohol-induced liver injury, or it could be because of any acute viral hepatitis. All these parameters, and resveratrol also can be tried. And if you're going to look into this vitamin A, remember, vitamin A prophylaxis program we can give up to 5 years of age. It's being universally recommended program as per National Hepatitis A Control Guidelines. So if you're going to use vitamin A, sometimes what is going to happen, a lethal injury can be there if you're going to use for at least a longer duration of time. There might be evidence of 1 to 2 years. Some patients have been recommended, some patients have been used for at least 3.5 to 6 years also. If you're going to use this for a longer duration, that shows evidence of non-cirrhotic portal hypertension may worsen and your liver enzymes may alter because of long-standing vitamin A supplement. You should remember that nutraceuticals should be used in proper manner if you want to manage. And niacin is also one vitamin B3 which is being used when you're taking a massive supratherapeutic dose. That also will be predisposing to your hepatocellular injury and other pathways which is going to get happen. So various herbal supplements, huge list, and over-the-counter medications, huge list are there. If you're going to look into that, aloe vera is commonly used. Various of might be predisposing for your weight loss when you're going to use without consulting properly, without analyzing your clinical status properly. That shows evidence of your hepatocellular injury to happen. So how are you going to adjust? The next area is briefly about your geriatric population. When you're going to target your geriatric population who are being crossed more than 70 to 80 years of age, so the hepatic metabolism is going to come down, your pharmacology, physiology changes is going to get altered. So many drugs are metabolized, they're going to get metabolized slowly, and there might be evidence of accumulation if you're going to prescribe the patient for a longer duration of time by your oxidation, your dealkylation, your reduction, nitro reduction, various drugs are there. So always you should take all these parameters into account when you're going to manage any kind of patients. And before concluding, what is the main thing I would like to share? When you're targeting a patient for managing a patient with liver injury, always you need to look for the common etiology. Look for the common clinical presentation. Assess the clinical status of the patient. See the age of the patient. See the sex of the patient. Look for the clinical picture. Look for the hemodynamic status. Check the pulse, vitals, all those things. See whether the patient is having acute presentation or see whether the patient is having chronic presentation. Look for his nutritional status, whether the patient is well-nourished or malnourished. Right from pediatric age group to older population, various etiological factors are there predisposing to liver injury, jaundice, hepatocellular injury, and finally the liver cirrhosis and liver carcinoma to set in. So why I would like to point out, look for the precipitating factors like alcohol, your coexisting thyroid, your coexisting hypertension, your coexisting metabolic syndrome, all of the profiles, and morbid obesity. If your BMI, if it is going to be more than 30, significant pointers to be taken into account. All these things to be considered if you're going to target the patient, that you're looking only for the drug-induced liver injury and yield your diagnosis with basic workup like your imaging and your basic ultrasound, your basic blood investigations. Look for the common viral markers. And in case if the patient is going to have a worsening of symptoms, first remove the trigger because of drug-induced means eliminate the trigger first, see whether the patient is responding or not. In case if the patient is not responding, do a proper liver biopsy and conclude whether the patient deserves liver transplant or not, and look for other comorbidities that what have been discussed and refer the patient promptly to overcome all the complications successfully. With this, I would like to rest my presentation, and I'm happy to take up your questions if anything is there to take on. Thanking you all for patient listening. Any questions to take on, madam? My voice is audible? Whether my voice is audible, sir?
Yes, sir.
Yeah. Thank you so much, Dr. Arun. It was an elaborative, excellent presentation. Actually, as a personal, I liked the last part of your presentation where we wanted that changes which we have to be alert in prescribing the drugs to the patients with liver problems. Thank you so much, sir. I would like to invite 1 or 2 questions to sir.
One question, sir. Based on your clinical experience, can you enlist the drugs that you came across which cause DILI? Can you tell the current chemotherapeutic regimen for hepatocellular carcinoma?
So our clinical experience for drug-induced liver injury as a gastroenterologist, most commonly we have been reporting is anti-tuberculosis in India, because the one drug, rifampin and isoniazid, not only been prescribed for tuberculosis. If you are going to look for any dermatological conditions, most of the dermatologists have been prescribing these molecules, and sometimes even for your being predisposing to drug-induced liver injury. So I would like to point the patient, once you're going to see this kind of scenario as drug-induced liver injury, we need to rule out all coexisting parameters. The drug-induced, I think my voice is audible, my internet connection is a bit stable. The drug-induced liver injury is mainly by your diagnosis of exclusion. So the most common scenario by your dermatological molecules as well as your anti-tuberculosis molecules. And apart from that, if you're going to suspect a patient with hepatocellular carcinoma, the most common chemotherapeutic regimen, what we have been trying, once the patient is going to land up with BCLC. What do you mean by this BCLC? It's nothing but a Barcelona clinic liver staging system. In that staging, there is 0, A, B, C, D, various gradings are there. If you're going to look into this, once the patient is going to deserve a chemotherapeutic, which means the patient is going for an advanced regimen, it's only a supportive care. Once a patient deserves a supportive care, the prognosis of the patient is very, very poor. So what you're going to do, you need to start the patient on basic first-line molecule like your sorafenib. It's nothing but your basic endothelial growth factor, all these things is going to get inhibited. So if you're going to get sorafenib based upon your short trial at a dose of around 400 to 800 milligrams, that might be evidence of worsening of your clinical parameters. Sometimes some drugs can predispose to liver injury. Nowadays, so many immunomodulator molecules being tried for this hepatocellular carcinoma. That's a separate area for discussion. The common molecule like sorafenib, what you're going to use, you should be very cautious when you're going to prescribe. Always you need to look for other coexisting parameters like your dermatological manifestations like hand, foot, mouth diseases being more commonly reported when you're going to use sorafenib for a longer duration of time. So why I'm saying be very cautious when you're prescribing a molecule, sir.
Any more questions? Thank you so much, Dr. Arun.
What is the commonest pediatric drug that causes liver injury day-to-day usage, sir?
The commonest pediatric drug is none other than paracetamol, madam, because as I had previously been discussed with you, the pediatric drug which causes most lethal liver injury, because once you stop the drug, the possibility of reversal of events is it's more commonly been reported in pediatric age group. But once a patient is going to land up with liver failure, like if the INR, if it is going to be more than 5, your sensorium, if it is going to come down, your coagulopathy, as I discussed with you, your acute liver failure parameters, your worsening of jaundice, your bilirubin, if it is going to be more than 5, that shows evidence of acute, it's an umbrella terminology. So once the ALF, if it is going to get happen, that's the most common aspect. King Edward criteria, King College criteria, what they mentioned, it's mainly because of your paracetamol toxicity. Why means various formulations in India, it's not been properly organized, because if you're going to use drops, almost 100 milligrams per ml, if you're going to use suspension, various formulation, 125, 120, 250, 240, and some manufacturers coming with 500, so many different molecules, sometimes 650, also 1,000, 1 grams. So many different molecules are there. So that's why the confusion is still going on. And most of the pediatric population is being highly vulnerable, because there are almost around 5 staging systems for this, for this hepatocellular injury to progress because of paracetamol poisoning. Paracetamol not only progressing to your liver injury, at end stage it will also progress to your renal injury. Also, you should be very, very cautious when you're going to use paracetamol. Early initiation of N-acetylcysteine at a dose of around 140 milligrams per kg, followed by, if you're going to give at a rate of around 70 milligrams per kg for a longer duration of time, at least around 40 to 72 hours, followed by you need to assess a clinical response, whether the INR, all these parameters, whether it is going to improve or not. All these parameters to be taken into account when you're going to manage a patient with paracetamol poisoning. And apart from that, rat killer paste, so many other toxic environment like paraquat poisoning, so many things which will predispose to, and the toxic drones is a separate area for discussion. But since lack of time, I don't want to progress into such areas.
Yes, thank you so much, sir. For want of time, let me request all the participants to share your queries if you have in the chat box. We will pass it on to the speaker and he will respond to you in any WhatsApp group or in the chat box. Thank you so much on behalf of the